Dear colleagues, shall we start again? It's a pleasure to introduce Professor Mahmoud Abdallah from Ain Shams, and he will speak about difficult to treat areas.
Thank you, Peter, and thanks for coming. I'm going to talk about difficult to treat areas. When we mention difficult to treat areas, we mean by that 5 areas: the face, the scalp, the genitals, the intertriginous areas, the palms and soles, and the nails. And maybe the lower legs, because often the lower legs are difficult to treat. Why they are difficult to treat? The diagnosis is often very difficult. Physiological properties, drug absorption and penetration are not easy in these sites. There are physical barriers like in the hair and in the nails, and these areas are mostly of cosmetic concern. They cause a lot, they increase the disease burden, the pain, the itch, the fatigue, the impaired mobility, and also patients who have involvement of difficult to treat areas usually have a higher DLQI than those who do not have involvement of difficult to treat areas, as you see in this graph. The assessment is usually, if we assess only difficult to treat areas, we usually use body-specific scoring systems. For example, the scalp modified PASI, or the psoriasis scalp severity index, or for the scalp, or the NAPSI for the nails, or the IGA specific sites. When we look at treatment success, we can either follow dedicated studies, which are only dedicated to the areas involved, or subpopulation analysis, in which we look at a post hoc analysis of moderate to severe plaque psoriasis trials. Usually dedicated studies are more accurate in assessing the efficacy of drugs because they have a better selection criteria. So starting with scalp psoriasis, the scalp is the first site in 25% of cases. It is involved in 80% of cases, and the frequency increases with increased duration. Usually the patients have thick plaques, significant discomfort, transient hair loss, thinning, and high visibility. Topicals are not very acceptable by the patients because they are difficult to apply, can make the appearance of the patient's hair unacceptable, and so affects compliance. External ultraviolet therapy may be used. However, it is better to go for excimer or focused ultraviolet. This is an algorithm published in the year 2021 for treatment of scalp psoriasis. If the patient has mild to moderate or severe psoriasis, we should start with topical therapy. If he doesn't have involvement of other body sites, he doesn't have moderate to severe psoriasis in other sites. If you have moderate to severe psoriasis in other sites, we have to go for systemic therapies from the beginning, including the traditional systemic agents and the biologics and small molecules. For traditional systemic agents, the rule is what works for the skin, for the glabrous skin, works for the scalp as well. However, we don't have enough data about the success of traditional systemic therapies in scalp psoriasis. For patients with mild to moderate psoriasis without involvement of the rest of the body, we can go for topical corticosteroids, vitamin D analogs, or a combination of both, keratolytics, and crude coal tar preparation, which in my opinion is the best option in these patients. If this doesn't work, we can do targeted phototherapy, or we can do intralesional corticosteroids if the patient has only localized involvement. For patients with severe, we don't do, with severe scalp involvement, we don't do intralesional injection. We just apply topical scalp phototherapy or go for systemic therapy. Usually we start with topical corticosteroids, and we expect the results within 3 to 4 weeks. We can also do occlusive therapy and add vitamin D and keratolytics to topical corticosteroids. If the patient is improved, we can either do intermittent as needed therapy or do maintenance therapy, like use the treatment twice a week to maintain. Secukinumab has a dedicated study in treatment of scalp psoriasis, and it shows good success after 12 weeks with 71% reduction in the PSSI. However, other drugs work as well. This is one of my patients treated with adalimumab biosimilar, and this is actually 2 months after treatment. Another case from my series showing success of adalimumab biosimilar. This patient has been treated with guselkumab. However, here comes the question, which is better? In a retrospective study of 308 patients with scalp involvement, anti-interleukin 17 was superior to anti-interleukin 23. And this was evaluated at week 16. In another single center retrospective study, the similar results were shown, and anti-interleukin 17 was superior to anti-interleukin 23. However, if you look at the graph on the top, you will see that anti-interleukin 17 is superior. However, with time, they will reach the same point, and even the results after week 96 are better with anti-interleukin 23. This is a network meta-analysis looking at different drugs used for scalp psoriasis and evaluating the physician global assessment of 0 to 1, which is clear or almost clear. And it has shown that the most efficacious drug among the studied drugs was secukinumab, followed by deucravacitinib, bimekizumab, and adalimumab. Moving to the face, facial psoriasis is associated with higher whole body PASI scores. They are more likely to have Koebner phenomena, more likely to have a longer disease duration, earlier onset of disease, commonly associated with nail involvement, and 5% of psoriatic patients will have photosensitive psoriasis. According to Professor van der Kerkhoff, the facial psoriasis could be categorized as either peripherofacial or centrofacial or mixed. The worst is the mixed. The centrofacial is usually associated with higher PASI than the peripherofacial. The treatment is challenging as well. Topicals may not be cosmetically acceptable. The site of the face is prone to steroid atrophy and steroid-induced acne, and incomplete clearance is particularly not accepted. Topical calcineurin inhibitors are not always tolerated on the face. Tacrolimus usually works better than calcitriol. Ketoconazole may be added, especially in patients having the seborrheic pattern. And we don't have a lot of data about systemics, but adalimumab has shown superiority over methotrexate in treatment of facial psoriasis. Intratriginous psoriasis, it is characterized by shiny, pink to red, sharply demarcated thin plaques with much less scales, with often a central fissure. This is how it looks like. This central fissure is a clue for psoriasis. The most common involved sites are the axilla, the inguinal crease, the intergluteal cleft, and if only the flexures are involved, we call it inverse psoriasis. Triggers might include localized dermatophyte, candida, or bacterial infection, and sometimes adding an antifungal is useful in these cases. This is one of the cases under the breast and the groin, and the dermoscopy is often helpful in diagnosis of these cases because many of them don't have really scales to see. The prevalence of genital psoriasis is very different from one publication to the other. However, it is more common in men, and the different percentages is attributed to the patient and the physician. Usually the patients don't mention that they have genital involvement unless inquired by the physician, and sometimes they are embarrassed or they are not aware that this is related to psoriasis at all. There is increased percutaneous absorption in this area, and so again, atrophy is common with corticosteroids. and the diagnosis is often challenging because we don't have scales and is often mistaken for candidal fungal infection, which delays the diagnosis. We can treat it either with topical corticosteroids for a short time, mild to moderate potency, topical vitamin D, which is again not always tolerated in this area, topical calcineurin inhibitors, or tapinarof and roflumilast, which are both FDA approved and have positive data in treatment of genital psoriasis. Crisaborole could be also used off-label in these sites, and there are some published case series about that. Phototherapy, it was mentioned today morning in the phototherapy that it is not advisable to expose the genital area to ultraviolet. However, this is very controversial because the recent trends does not find any contraindication for exposing this area to phototherapy. Systemics, we can use methotrexate or biologics, and apremilast has a dedicated study in treatment of genital psoriasis. Ixekizumab as well has a dedicated, this is maybe the only biologic that has a dedicated study discussing the treatment of genital areas. Moving to the nails, nails are reported in up to 80% of psoriatic patients. Fingernails are more commonly involved than the toenails. Toenails are really difficult to diagnose, especially if they are the only site of involvement. There is increased incidence of psoriatic arthritis, mainly distal interphalangeal joint arthritis. 70 to 80% of psoriasis have also nail involvement, and 1 to 5% have only nail involvement. The nail may involve the matrix, which is characterized by pitting, crumbling, leukonychia, and red spots in the lunula, or the nail bed, which is characterized by subungual hyperkeratosis, salmon patches, onycholysis, and splinter hemorrhages. These are the signs you can see and diagnose. Oil drop and splinter hemorrhages are usually very useful. We use the NAPSI score in assessment. And we have a lot of challenges when it comes to the nail. It is effective drug concentration is difficult with topical therapies. The slow nail growth make the therapy response hard to assess, and it can be difficult to diagnose and to distinguish. We can use corticosteroids, vitamin D analog, topical retinoids, or intralesional steroid, which is often not accepted by the patient. However, in patients with up to 3 fingernails involvement, this would be the first choice of treatment. If you apply the topicals, you should, if you are treating nail matrix manifestation, you apply the ointment to the proximal nail fold. While if you are treating the nail bed, you do clipping of the nail and apply it to the hyponychia. Methotrexate and cyclosporin show almost similar results in treatment of nail psoriasis with a 40% reduction at week 24 in the NAPSI score. However, the methotrexate works mainly for the matrix, and the cyclosporin works for both the nail bed and the matrix. Acitretin also has shown 41% reduction at week 24, and in another study 51% reduction at week 48, and this is one of the good treatments for nail psoriasis in my opinion. When you look at there is a network meta-analysis which has shown that at week 24 to 28 the best solution is ixekizumab, followed by brodalumab and bimekizumab. So actually interleukin 17 again work best for nail psoriasis, followed by adalimumab and guselkumab. At week 48 to 52, guselkumab is not included here. However, again, ixekizumab gives the best response, very close to adalimumab. No role for phototherapy in nail psoriasis. It doesn't work at all. However, we can use laser like pulse dye laser and Diag laser, IPL, and I have published that a few years ago. This is one of my cases treated with pulse dye laser for nail psoriasis. This is another patient that I have treated with pulse dye laser. Moving to the palmoplantar areas, we can also, palmoplantar areas are either hyperkeratotic palmoplantar psoriasis or palmoplantar pustular psoriasis, which is a different entity from the whole psoriasis. So we are going to concentrate mainly on hyperkeratotic palmoplantar psoriasis. The challenges, the treatment goals are to alleviate pain and function because the palmoplantar psoriasis has many functional, social, and occupational side effects. We can use tar-based soaps, compounded products, vitamin D analogs, methotrexate, acitretin, both work in palmoplantar psoriasis, however, with modest efficacy. This is one of my cases treated with adalimumab biosimilar again, another case treated with guselkumab, and another case treated with guselkumab successively. However, after 2 years, he had a secondary failure and was given exicuzumab. Looking at the network meta-analysis again concerning palmoplantar psoriasis, this was a research letter published in the JAD last year. Guselkumab shows the best results, followed by bimekizumab, followed by adalimumab. This is another network meta-analysis which shows secukinumab to be the best, followed by guselkumab. So we have discussed today the treatment of difficult to treat areas. We still need a lot of work on that, especially evaluating the conventional therapies in treatment of these areas. Thank you very much.
Thank you very much for this really outstanding presentation. It's extraordinarily important that you pay attention to difficult, to high impact site, as we say. And it is also within the International Psoriasis Council, we have a program now on where the evidence is not sufficient, for there are a lot of data around, often not such huge studies, smaller studies, but it is important to bring the knowledge together in good treatment paradigms. And you have shown us also in palmoplantar psoriasis what a biologic can do there. And we know all the years history that many patients have a very difficult impact on quality of life. And you showed some of these results, which are very good. I was intrigued by a remark that you had right at the beginning, and that is psoriasis on the lower legs. And for me, in teaching sessions, it was always when colleagues say to me, psoriasis on lower legs is a difficult to treat area, then always my answer was, that means that you see a lot of patients. For it is absolutely true. I have been working in Nijmegen with a phlebologist, and he did also some measurements in those days, venous emptying rate and that sort of things. And he showed indeed that the venous emptying rate was abnormal in patients with these very resistant lesions. And we were used to treat these patients with compressive bandages. And following that, we saw that these difficult to treat areas responded very nicely to a topical. What's your evidence, my dear colleagues, is zero. So in times of evidence-based information, I should say, it is, but I was really struck by that. And we will discuss that also in our council and refer to this meeting here, that it is important to consider whether the lower legs should be a high impact site. Firstly, it's a high impact site and difficult to treat site.
Yeah, we have a lot of patients who the whole body responds well, and you are left with resistant plaques on the legs. Usually what I do intralesional injection of steroids in these sites because topicals do not work as well.
Oh, with compressive bandage or
I will try that.
when possible elastic. This it's really well. Maybe it can be patented. But still, questions from the audience. Yeah, Jörg.
Thank you very much, Professor Abdallah. I was also very impressed by this very well-structured presentation, which is educative for me as well. Two questions. How about the colonization of the scalp by yeast, Pseudosporium follicular?
Yeah.
Are you addressing this by anti-mycotic treatment in order to improve it? And the second issue is palmoplantar pustulosis in patients treated with TNF antagonists. Do you have experience how to get this under control?
Thank you very much. Well, concerning, yes, we sometimes do give ketoconazole shampoo for these patients, and I think it helps. I think it helps especially when I treat my patients and it doesn't go well. I usually apply ketoconazole and to get rid of the yeast colonization. Concerning palmoplantar pustulosis after TNF, I think I would go for something like acitretin or systemic steroids in some cases, having that. I'm not sure how you treat these cases. I need to listen to your opinion as well.
Excuse me.
Should I?
Yeah,
mean,
I just want to listen. What I do, I give acitretin and sometimes
okay.
short courses of corticosteroids.
Yeah.
But I need to listen about your experience in these cases.
We still also have the same trouble that we don't have a really good strategy. When patients with gastrointestinal Crohn's disease or colitis are treated with TNF antagonists, they often develop palmoplantar pustulosis. And in these patients, acitretin is contraindicated because it may aggravate the intestinal inflammation. And therefore, we are really limited in what we can do. And I thought
maybe
you might have some experience.
Cyclosporin.
Cyclosporin, yes, whatever.
Yeah.
Thank you.
Thank you.
Thank you, Dr. Mahmoud. Now, it's an honor to introduce my professor and role model, Dr. Mahira Sayed. She will talk about psoriasis in children.
Good afternoon, everyone. Thank you very much, Dua, for your kind introduction. And I want to welcome again Professor van der Kerkhoff, Professor Prince, for being with us today. I'm going to talk about another difficult to treat subject, which is psoriasis in children. Those are my disclosures. It's a very challenging disease, both in terms of diagnosis and in terms of treatment. When I was a resident 40 years ago, they used to tell us psoriasis in children, it will go away in time. And they used to tell us it's harmless and the patient will improve. But we discovered later on that this is not true. We have to treat psoriasis very early because, first of all, 1/3 of the cases of psoriasis begin in childhood. 30% of children have a first-degree relative affected between the age of 7 and 10, and it can occur at any age. The problem with pediatric psoriasis, there is very little data. We use a lot of medications off-label from other specialties. We need to consider the burden of the disease and approach the patient holistically in terms of also the comorbidities. The risk factors or the triggers, like we were talking this morning about adult psoriasis, they are much similar. First of all, we have genetic background, and then we have either extrinsic triggers or intrinsic triggers, whether they're drugs, infection, teenagers, of course, smoking and alcohol, mechanical stress, and all the other comorbidities like metabolic syndrome, obesity, diabetes, and so on. In children in particular, there is a lot of Kebner phenomena. Infections have to be considered. The Professor Prince was talking this morning about strep infection of the throat and the stress. And we have to look for the infection not only in the throat, but also perianal strep infection. And if the culture is positive, I need to treat them. But sometimes as well, viral infections can trigger psoriasis like measles or chickenpox, for example. This was, I was talking about this morning, that this was a meta-analysis that was done about all the trials done about intervention for guttate and chronic plaque psoriasis in terms of tonsillectomy. They found 5 trials which assessed the effects of antibiotics, and there is very low quality evidence consistent with the outcome measures. So I think we need to study this personally on our patients. It's important. The clinical features of psoriasis in children is the same as in adult, though it's more itchy. Psoriasis is more common in girls. The lesions are thinner, softer, less scaly. They may differ in distribution than those reported by adults, because we will find more facial psoriasis, more flexural psoriasis, especially in the diaper area, compared with adults. And the plaques are usually much smaller, so sometimes they're quite difficult to diagnose. Those are the clinical presentations of psoriasis in children. We have plaque, erythrodermic, guttate, invert psoriasis, palms and soles, pustular, annular, linear. All those can be affected. Also, half the patients have scalp affection, and we do also have nail and mucous membrane affection. Napkin psoriasis is one of the commonest presentations we see. It's not the commonest in children because the commonest is plaque psoriasis, but we misdiagnose it a lot. I have to be suspicious when I have rash in the diaper area, which is not responsive to treatment, sharply demarcated, minimally elevated plaques. These are some examples of the way diaper psoriasis may look. And this is one patient that has taken so many topical steroids that there is some atrophy of the skin as well. This is another patient, but this is quite obvious because there is this well definition and the scaliness of the lesion. The second type is plaque psoriasis, which can occur any place, palmoplantar like in adults. Those are all examples of plaque psoriasis that occurs in children in any area commonly affected by the disease. We also have guttate, which is self-limiting, and if we discover that there is caused by a strep infection, sometimes if we treat the infection, it becomes self-limiting and it will disappear on its own. Scalp, very commonly affected, so each child at any age, I must examine the scalp very well. So those are examples of scalp psoriasis, and you can see that also other areas are affected, like behind the ear. And you all know that the difference between, sometimes it's hard to differentiate between scalp psoriasis and seborrheic dermatitis, but psoriasis usually in the scalp extends beyond the hairline, which is quite diagnostic. Nail affection also occurs in children, and it's very, very challenging to treat. And sometimes you only get nail psoriasis in children, which is disfiguring and highly affects their quality of life. Psoriasis in children also causes comorbidities, and all the papers are advising us to screen for obesity, hypertension, of course, psychiatric disorders and anxiety, also diabetes mellitus. So don't forget that psoriasis in children also is associated with comorbidities exactly like in adults. How am I going to diagnose? There are certain areas. This was like a Delphi study made a while back, and to find the most common areas affected by psoriasis in children, look at the umbilicus, the nappy area, the folds behind and inside the ear, and remember that there is prominent Kepner phenomena, and it's very, very itchy. And these are areas you need to look for when you are examining a psoriasis patient. Please look at all these areas to make sure that they are free of psoriasis. Sometimes it's hard, this dermosco in my hip sometimes. I only biopsy the patients if I suspect or if I cannot really reach a clinical diagnosis, because biopsy in children is hard. This is courtesy of my dear colleague, Professor Hoda Munib. Dermoscopy, I will find this dotted vessels and red globules arranged in a regular homogeneous pattern. Professor Mahmoud a while back has showed you how it looks like. It's also very helpful in areas where there is no scales in the lesion itself. Psoriasis in children is challenging because it can be misdiagnosed. Atopic dermatitis, or sometimes pityriasis rosacea, fungal infections. There are a lot of differential diagnoses that should be considered in the children. And it's sometimes, to be honest, it's very hard from the first time to be very sure about the diagnosis. What about the assessment tools for disease severity? We have mild, moderate, and severe, like in children, and very recently, the International Psoriasis Council Pediatric Working Group has been working on the applicability of these adult definition of disease severity for psoriasis in children. And I think they're about to publish this manuscript, and this is going to be very useful because we do not know if the severity classification can work for children like in adults. A lot of papers were published talking about the challenges in treating psoriasis in children. First of all, there is a higher penetration of pharmacological agents, so you might get more side effects. There is variation in the efficacy and safety of the agents, different in metabolism and penetration and distribution, and a lot of things. A lot of the treatments are off-label, by the way. This is what we have right now. We do have topical treatment. I can use conventional systemics. I have phototherapy, and I have the biologics, all starting from etanercept up to ixekizumab. All these biologics have been approved for children. Topical treatments, you all know, steroids, vitamin D analogs and steroids, calcineurin inhibitors, Detranob, but you have to be careful, especially with vitamin D analogs in sensitive areas and in very young children. Emollients are great. Sometimes I only use emollients, like this is a one-year-old child that came to me. I just use a regular emollient because there's quite a surface area and I couldn't give anything else. And there is quite an improvement after the simple use of an emollient. I know it helps a lot, but at least it will spare me the use of topical steroids for a very big surface area. This I gave mometazone furoate only for 10 days, and there is a great improvement because the problem we've got really is that calcipotriol is irritant, systemic absorption in topical steroids in children. I can cause skin atrophy. I do rebound. So the only thing is either I shift to weekend treatment or I can use TCIs in order as a steroid-sparing drug. What about phototherapy, narrowband? Both can be used, either a narrowband in diffuse guttate and thin plaque psoriasis. I can also use PUVA and broadband, but in an older age. Conventional systemics can be all used. And at the very beginning, when we started treating children with psoriasis, we were worried about methotrexate or retinoids or cyclosporin, but I think they're great drugs. Methotrexate is a great drug in children, and it gets wonderful results when used on the correct dose and with the correct monitoring. Now, the management approach should differ with age. If you have a neonate or an infant under 2 years, you just be very conservative in the way you treat those patients. Now, the childhood or the prepubertal or the adolescent postpubertal, I can have to realize how impactful the disease is and start treating those patients like I would treat adults exactly. The biologics, when should I consider biologic treatment? Especially in severe cases, rapidly evolving, debilitating, affecting the quality of life, affecting the family itself. And this is a paper that was published comparing the treatment with methotrexate and the biologics. They both were associated with a great reduction in the PASI score, but they found that the drug survival was better with the biologics than methotrexate. So should I use? Those are all approved. Adalimumab, etanercept, ustekinumab, secukinumab, ixekizumab, all from as early as the age of 4 and 6. So I think this is great. I have participated in the trial for secukinumab in the pediatric patient. It was published, and this was a pooled analysis to understand the safety of the drug itself. And then, so when we consider it, we exactly consider it as we consider with the adults. I've changed a lot my state of mind a while back when I understood that really children get impacted as much as adults do, and also their families are impacted. This is one of my patients who was treated with ustekinumab. This patient has taken methotrexate, he took acetretin, he took Enbrel, and then we shifted on ustekinumab, which was just approved, and to be honest, with marvelous results. And up till now, he takes an injection now every 3 months with great results. So I'm spaced. I know this is off-label, but his mother will not stop the treatment for anything. Most of the guidelines, the German guidelines or the treatment guidelines for the American guidelines, all the algorithm are talking about the biologics. Like I said, a lot of those treatments are off-label. But what about this business of the proactive treatment? I found this very interesting because I need to tell the mother what to avoid, the triggers for the flare-up, the use of the emollients, weekend therapies, always keep the patient under control. This will improve the therapeutic safety, reduce cumulative doses, and reduce the doses, and this will help me a lot. And this is an important message because this concept of proactive treatment will help limit the duration and the severity of the disease, will improve the quality of life, and those are really simple measures. Losing weight is important, controlling healthy lifestyles, playing sport, maybe like Professor Prince said this morning, maybe the diet can help a lot. So I think this is great. I think the future holds newer targeted therapy with earlier intervention that might modify the disease course. So I think we have to treat moderate to severe psoriasis, though it's very challenging in children. Now, accumulating data and gaining familiarity with new and emerging targeted therapies, we continue to build on this collective experience. So because children really have a potential lifetime ahead of them, so we have to consider long-term safety, and this is another thing. For how long can I keep giving the child the biologic? But they hold a potentially exciting future, but maybe very soon we can find treatment to clear psoriasis completely. And thank you very much.
Thank you, Professor Mahira. Amazing as usual. Any questions? Okay, so our next, thank you very much, Professor Mahira. Our next speaker is Dr. Amin Sharubim, one of the psoriasis KOLs in Egypt from the National Research Center, and he's going to give a lecture about comorbidities and disease burden.
I would like to thank all the organizing committee for this chance. It's a bit challenging to illustrate the psoriasis comorbidities and disease burden, so I'll try to be fast. So now we know that there is a global burden for psoriasis. And as we can see, there is a steady increase of psoriatic cases all over the years. And this is bringing more than a burden for all our patients, because psoriasis is more than a skin disease. It do a lot of impairment, and it has associated with a lot of comorbidities like metabolic syndrome, cardiovascular disease, and anxiety and depression. So we can say that it's more than a skin deep. Psoriasis is a systemic disease, and it is associated with many comorbidities. More of them, the most important, are metabolic disease, diabetes, obesity, cardiovascular disease, depression, and anxiety, other comorbidities as ocular inflammation, Crohn's disease, psoriatic arthritis. So now you can see that we have, like we said, the psoriatic comorbidity or the sphere of the psoriatic disease. And we can see that it starts with the skin, then we have the systemic disease, then start the stigmatization and the quality of life impairment and the cumulative life impairment, as we can see. And with the definitely with the right intervention in the right time, we can stop this fear of disease, either with diet, with other drugs for the comorbidities, and of course we can stop the march of this psoriatic march. Psoriasis also has a financial burden. And as we can see, that severe psoriasis is associated with the greatest work productivity loss and highest rate of absence and disabilities. And also the hard to treat disease, as Dr. Mahmoud was saying, the body location data from the damaged skin, as we can see, it is associated with a lot of disease burden and financial burden as well. We have the comorbidities, as we can see, that the psoriasis is associated with high co-medication morbidity. So a psoriatic patient with a significantly higher co-medication burden, more than the patient with less psoriasis or with mild psoriasis. So we have also a co-medication burden, as we can say, and you can see that the different diseases with men and women, they are, with the severity of the psoriatic disease, they are more co-medication burden, as we can see. Pediatric psoriasis, as well as Dr. Mahira was saying, that there is in pediatric psoriasis, the comorbidities are more increased than adults, and that's always this is missed. The psychological risk is more profound in pediatric psoriasis, 9-fold increase with the anxiety, and 6.5 time decrease with the depression. And early detection of these comorbidities, especially in children, it has a greater impact on the life course of the psoriatic patient, and that's what we call the cumulative life course impairment. We have always to think about the cumulative life course impairment of the disease of the patient with psoriasis, especially patient with severe psoriasis, and pediatric patient or young patient diagnosed with severe psoriasis. And we can see that the impairment of the life's cumulative, it starts early in children, and it increases with age, the cumulative life impairment, as we can say, and there is an area where there is a reversible damage in spite of the healed skin of the old of the disease, and this is what we can say, that there is a very window of the early intervention. When the right intervention is there, we can, with this right intervention, we can stop the cumulative life course impairment. And if the intervention, it is late or it is delayed for this patient, now that's the irreversible damage. It's happened in all the organs. So that's why that we can see the cumulative life impairment course and the early intervention has a great impact on the decreasing or stopping the psoriatic burden disease on these patients. Now we can start, we say that we believe that at least 73% of the patients of psoriasis have at least one comorbidities. And psoriasis, as we said, is not a skin disease, it is a systemic disease. And we have 50% in severe psoriatic patient increase of risk of mortality. And now the role of a dermatologist, who is the healthcare provider, is not only to treat psoriasis, but to pinpoint all these comorbidities and to do multidisciplinary approach for these patients to treat them with all their comorbidities. And that's why, because we have a chronic inflammatory state with a lot of bad pro-atherogenic or pro-inflammatory cytokine in comparison to the normal or the anti-inflammatory cytokines which happen in the psoriatic disease. So the most famous comorbidities and the most common comorbidities we can see is the obesity, diabetes mellitus, hypertension or cardiovascular disease, and metabolic syndrome, and we'll have a glimpse on these. There is other comorbidities like obstructive sleep apnea, osteoporosis, pulmonary disease, uveitis, psychological disorder, but one of the most important is arthritis and psoriasis. And the GRAPPA told us what are the simple criteria of the psoriatic arthritis, the inflammatory, the enthesitis, the dactylitis, and the spondylitis. Now we know them. Why we should care about the psoriatic arthritis? Psoriatic arthritis is much more serious than previously recognized. 20% of patients with psoriatic arthritis develop clinical deformities and irreversible damage resulting in functional disability. So after 10 years of follow-up, up to 55% of patients have more than 5 deformed joints. And that's we can see that the inflammatory state that happened in these patients, it attacks the joints and attacks the ankle, as we can see, by the effect of the TNF and the interleukin 23 and interleukin 17. The presence of nail psoriasis, scalp psoriasis, and flexural psoriasis should raise the suspicion of the association of psoriatic arthritis. Hyperlipidemia and localized pustular psoriasis were found to be predictive also of psoriatic arthritis. The PASI score is higher in the psoriatic arthritis patient than those with psoriasis alone. So we have some suspicions. clinical signs that can predict of psoriatic arthritis of this patient. Signs that increase risk of psoriatic arthritis, it is the scalp, nail lesion, intranasal and perineal lesions, and the psoriatic severity. So screening for the psoriatic arthritis should be done in these patients, as we can see. Also in the cardiovascular, the pathogenic of chronic plaque psoriasis and intersection with cardiometabolic disorder, as we can see that the chronic inflammatory state in the psoriasis, it affects the metabolic syndrome, the obesity, and it leads to cardiovascular disease and non-fatty cardiovascular disease and non-fatty liver disease, hypertension, dyslipidemia, and finally psoriatic arthritis, as we can see. And the cytokine role, as we can see, chronic inflammatory, it affects all these. Now, this is a very famous picture with when doing the MRI for when doing PET scan MRI for this patient. We can see that the psoriatic patient, as we can see, they have a lot of inflammation in all the system of the body, especially the endothelial system and the liver, vasculature, and the joint, and that means that these patients are more have comorbidities than normal patients. Metabolic syndrome, the central obesity, as we can see, it is affected. There is a strong association between increased obesity and psoriasis. There is a strong association between the body mass index and the central obesity and psoriasis. And because the subcutaneous fat play a role as endocrinal organ and it increase the cytokine inflammation in these patients, so patients had a higher prevalence and incidence of obesity when they have psoriasis. Also, obese patients had more severe psoriasis than normal patients, as we can see. And there is the increased adiposity is a strong risk factor for the incidence of psoriasis. So central obese patients are more risk to develop psoriasis than the normal patient, are more risk to develop diabetes and hypertension. The subcutaneous fat cell, as I said, it's act and endocrinal and organ secreting more pro-inflammatory cytokines as interleukin-6, tumor necrosing factor, leptin, as we can see. And these inflammatory cytokines, which is secreted from the adipose tissue, it increases more and more the severity of the psoriasis, as we can see, especially the resistin and the leptin. And of course, the anti-inflammatory cytokines are decreased in these obese patients, as we can see. Also in the cardiovascular risk, we can see that the conventional risk factor is more common in these patients due to the immunological process that they have, and the atherothrombotic markers, that it is increased with the psoriatic patient, as we can see, and severe but not mild psoriasis associated with increased risk of myocardial infarction, as we can see that the psoriasis and the cardiovascular disease, there is an immune-related crosstalk. We will see it as this picture, as this show that the interleukin-17 from the skin, it goes to the endothelial system, and it interacts on the interleukin-17 receptors, and it increases more and more secretion of ICAM and adhesion molecule, which increase more and more foam cells and leukocytes to promote and to form a clot and to be more atherogenic or atherogenic plaque. So the interleukin-17 and the tumor necrosing factor, they have a direct role on the endothelial system of this patient, as we can see that the systemic inflammation which is there, it affected the endothelial, and it includes more endothelial damage, as we can see. And in this endothelial damage, it promotes the formation of foam cells, more than foam cells, and this accumulation of foam cells, it will meet the atheroma or the atherotic plaque, and that's why these patients are more prone to prothrombogenic effect and cardiovascular risk, as we can see. So we can see that the hypertension too, the T helper 1, T helper 2 imbalance is involved in the pathogenic of atherosclerosis, as we saw. The pro-inflammatory cytokine, the interleukin, tumor necrosing factor, interleukin 5, interleukin 1, interleukin 6, it helps to develop more and more atheroma, and that the platelet-derived factor, that's a P-selectin, and the adhesion molecule are more secreted, are more increased in psoriatic patients. So as we can see that in psoriasis, there is the increase the intrahepatic collagen and a lot of inflammatory cytokines that leads to hypertension. It leads to non-alcoholic fatty liver disease that lead to atherosclerosis at the end. And on the other hand, the metabolic syndrome, insulin resistance, and increase the tumor necrosis factor alpha, also the inflammatory milieu would happen from the obesity and the diabetes, it increase also to the atherosclerosis. So there is a huge risk of cardiovascular disease with the psoriatic patient as comorbidity, which can be reversed and can be treated by treatment of this patient and systemic treatment. Take care that the risk, relative risk of myocardial infarction is increased with the decrease of age. So the risk is increased at the age of 20 years because the patient will develop, have a longer chance to develop atheroma and atherosclerosis by time. More than the patient with 70 or 80 years, he also has a small lifespan to develop the atheroma and the atherosclerosis. So early intervention is a very important to decrease the risk of myocardial infarction in this patient. Don't forget about the malignancy. The chronic inflammatory state in psoriasis may induce certain neoplastic disease, and what to look, this is have to look to breast cancer, cervical cancer, colorectal cancer, and lung cancer of this patient. Non-inflammatory, non-alcoholic fatty liver disease, which is the accumulation of triglyceride, is very important and should be looked for this patient. Psoriasis and the Crohn's disease, we can say that there are one phase for two. We can say that psoriasis is strongly associated with inflammatory bowel disease, and the prevalence of psoriasis in Crohn's disease is higher, and patient with 25% of patients with Crohn's disease referred to a dermatologist has psoriasis. And don't forget that the prevalence of comorbidities, Crohn's disease, it's always missed from us, but we have always to look for it because it is the third comorbidity in this patient. They share the same genetic, the same immunological pathway, and they share a lot of similarity, psoriasis and inflammatory bowel disease. So how far can psoriatic patient go? Don't forget an anxiety and psychological impairment. It is increased in this patient, and especially an anxiety and depression. We can see here that there is all the cytokine imbalance in psoriasis are found as the cytokine imbalance in depression. So we can say that depression here, it's not resulted from the skin disease. It's not resulted from the depression or anxiety for the patient doesn't look good and they cannot wear their clothes. No, but the cytokine imbalance, it affects directly the brain to produce more anxiety. And now we can say that it could include also not only anxiety and depression, but mild cognitive impairment. There is cognitive impairment in this patient. The cytokine imbalance do cognitive impairment and memory loss. It's one of the most chief concern in this patient, non-treated patient. Finally, I want to say that we have to check comorbidities. We have to check the glycosylated hemoglobin, measure the waist circumference, exclude metabolic syndrome for this patient. We have to do exclusion for the joints and do good examination for the joint, measure the blood pressure, ask about diarrhea and Crohn's disease, ask about all this stuff. Do you have to have a list of required lab to do for this patient and measurement for this patient. And that's it. Thank you very much.
Thank you, Dr. Amin. Very comprehensive lecture. Any questions for Dr. Amin?
Thank you, Amin.
It's my honor to introduce my mentor, Professor Mahira Hamdi Sayed, our psoriasis expert, who is going to talk about advances in management of pustular psoriasis.
Hello again. We're going to talk about a subject that's complementary to all what we have been talking about today. And again, we've called this session the Advanced Psoriasis, where we have all the difficult to treat parts of psoriasis. Those are my disclosures. The first 3 slides are courtesy of Professor Peter van der Kerkhoff, because all the time we talk about psoriasis vulgaris. We know the variants, we know the types, we know guttate, we know erythrodermic, but actually pustular psoriasis, or GPP, or generalized pustular psoriasis, was the road less traveled. The first published case in generalized pustular psoriasis was in 1910. It was published by von Zumbusch, and then 1968, the cohort study in the British Journal of Dermatology. And then for a very long time, nobody was looking at GPP. In 2011, the group in Tunisia and France by Professor Marakshi and Professor Hervé Bachelet, they discovered the interleukin-36 RM mutation. And from then on, I think that the trials started to get in, and GPP was recognized as a distinct disorder from plaque psoriasis, and the first FDA-approved therapy for GPP was admitted. Now, this is von Zumbusch, who published the first description in 1910, inflamed and thickened skin with pinhead-sized pustules all over the body. Flares were universal, and this was a patient that was described having 9 flares in 10 years. And then those are the group of patients that was published in the BJD in 1968, identifying the triggers as we know them today: hypocalcemia, pregnancy, infection, and sudden withdrawal of steroid therapy. What are the clinical features of GPP? It's characterized by rare, severe systemic disease, by erythema, pustular skin rash, often with extracutaneous organ involvement. In some cases, we can have life-threatening complications and other organ affection. And it is a distinct entity from plaque psoriasis, although they can occur together. But I will let you know in a minute why was it considered a distinct entity from plaque psoriasis. Now, this is the classification of Eraspen, who said that generalized pustular psoriasis, primary sterile, macroscopically visible pustules with or without systemic manifestation, with or without psoriasis, either relapsing or persistent, relapsing meaning more than one episode, or persistent for more than 3 months. And they also gave description to the PPP, which is palmoplantar pustulosis, and the acrodermatitis continua of Halopo. Now, the Japanese also gave a description, but both descriptions, they were not universal. For example, systemic symptoms were said by the Japanese to be, they have to be present, and Eraspen said with or without. Histology, the Japanese said it needs to be confirmed by histopathology. Lab abnormalities was absent from both, and Eraspen mentioned with or without plaque psoriasis, until IPC and Professor Chun has did a Delphi study and did the international consensus definition and diagnostic criteria for GPP from the IPC with Professor Chun and Professor Peter van der Kerkhoff. And what they did was, the objective of this was to develop a consistent definition to the disease. And because it's so rare, it presents a challenge in acquiring comprehensive published clinical data necessary to develop any standardization. They did Delphi rounds, the first and second modified rounds, 91% and 76% participated. In the initial Delphi round, consensus was achieved only for half the statements, leading to the approval of 23 statements that were utilized to develop the proposed definition. During the second round, the final definition was came up with like GPP is a systemic inflammatory disease characterized by cutaneous erythema and macroscopically visible sterile pustules occurring with or without systemic symptoms, with or without other psoriasis types and laboratory abnormalities. Excuse me. And GPP may manifest as an acute form with widespread pustule, subacute variant with an annular phenotype. So basically, it is characterized by recurrent episodes of widespread painful skin, having pain, itching, scaling, redness, burning, dryness, and also patients may have leukocytosis, neutrophilia, high CRP, hypocalcemia, hypoproteinemia. We have liver affection. We have sometimes up to cholangitis, edema, joint pain, and uveitis. These are some examples of some of my patients clinically. And just, this is a comparison. It is different. The lesions are different. GPP is different from plaque psoriasis, though over 65% of GPP give a history of plaque psoriasis. They already have psoriasis. So to my mind, and we were discussing this, and we discuss it a lot, is there a difference between patients who have JPP with psoriasis or without psoriasis? The lesion characteristics are different, as you can see. We all know the classic description of plaque psoriasis, which is completely different from the classification or the description of GPP. There are certain diseases that we have to differentiate from GPP. The most important is AGIP, which is acute generalized exanthematous pustulosis, which is mostly drug-induced. The onset helps us to diagnose, and if we are in doubt, sometimes a biopsy will help. We have a lot of eosinophils in AGIP. Also subcorneal pustular dermatosis, pemphigus foliaceus, or annular pustular psoriasis, like you see in this patient, which you can see that these are some pustules that developed around the psoriasis lesions. Histopathologically, again, they're different, characterized by the most important is the formation of Monroe microabscesses, which are prominent neutrophilic infiltrate, vascular ectasia, and spongiform pustules. Again, GPP pathologically different from plaque psoriasis, and this is why this, as you can see here in pustular psoriasis, there is this huge microabscess which is not present in cases of plaque psoriasis. Epidemiologically, it's not very common, but it may occur in children, and this is a 12-year-old child. This is one of my patients who keeps developing these repeated flares and bouts of GPP, and he actually responds reasonably to acetretin and some emollients and topical treatment. Now the flares, when a flare occurs, even when the patient is remission, they still have symptoms. So sometimes it's very difficult to differentiate between the actual flare ending and the maintenance phase. So the patient comes in with a flare, but even after improvement, he still has remaining skin lesions. And this is one patient in a flare, and even after we treat the patient, it remains, the skin remains affected. Why do a flare? The triggers are pregnancy, stress, infections, and steroid use or withdrawal. Despite treatment, they have residual disease, like we said, like this patient. Maybe we do not have any acute symptoms, like in terms of fever or acute CRP or neutrophilia, but again, the patient still has his skin affected. It's a very burdensome disease affecting the mental health, the work, the sexual activity, and when compared to psoriasis, it's even worse because sometimes the patients are really sick. It has a greater impact on the patient's lives compared with psoriasis, and several studies were done. They also have comorbidities like diabetes and hyperlipidemia, and they usually use antihypertensives and antibiotics. Now, very quickly, the disease mechanism, the GPP, is different from psoriasis. Those are all medications, environment, infection, genetic mutations, mainly interleukin-36 RN, CARD14, and AP1S3. Those are 3 mutations. All these will cause either overexpression of interleukin-36 or dysfunction in the interleukin-36R antagonist, resulting in uncontrolled signaling and linked to the development of GPP. This is to compare the pathogenesis in GPP and plaque psoriasis. As you can see, plaque psoriasis is related to the T cells and the adaptive immune system, while pustular psoriasis is related more to the innate immune system. Plaque psoriasis is multigenic rather than single gene driver, while GPP is discovery of the mutation in the interleukin-36RN gene showed that it's monogenetic. Again, the difference in the pathways are observed in GPP and plaque psoriasis. This is why they are both different from each other. When immunopathology was performed, a lot of neutrophils were found in lesions of GPP, and just all what we need to know that the interleukin, as this morning we were talking about the pathogenesis of psoriasis and how all the biologics were developed against the cytokines responsible for plaque psoriasis. The same thing happened when interleukin-36 was discovered, and then anti-interleukin-36 was, because this dysregulated signaling stimulates the cytokines, increases the inflammatory cell recruitment, promotes chemokine expression by all the keratinocytes, the neutrophil, and induces also systemic inflammation. So we need to understand that there is dysregulation of inflammatory signaling caused by interleukin-36 pathway, uncontrolled activation of the pathway. So if we stop the pathway, we can control the disease. It's self-perpetuating, like psoriasis exactly, and I think this morning Marwa explained this, but I found this very interesting because, as you can see, the 3 cytokines responsible for plaque psoriasis are responsible for pustular, but mainly the driver here is interleukin-17, and the driver here is interleukin-36, so it's the other way around. So, key takeaways, interleukin-36 plays an important role in JPP. What about the treatment? The treatment is unsatisfactory until now, but our goals is to control the pustules, prevent new eruptions, control the pain, control the itching, the redness, control the fever, prevent the complications systemically, whether renal or cardiac, prevent the acute respiratory distress syndrome. And this one was published in Experimental Dermatology, which shows the different treatments that are used in on GPP to decrease symptoms and cause disease remission. All the biologics have been used: retinoids, calcineurin inhibitors, methotrexate, apremilast, and finally, until now, spesolimab, which is the new anti-interleukin-36. So all these can be used according to the guidelines of psoriasis, and this is based on the clinical experience of plaque psoriasis. So Professor Chun from Malaysia, she's very experienced with GPP, and I keep asking her. She at one point gave those patients infliximab. They responded well. She said she gave them anti-TNF, anti-interleukin-17. That's before the development of the newer anti-interleukin-36. Because even when the patients are treated, they think they still have residual disease, scaling, erythema, skin lesions, pustules sometimes, plaques, and there is a lot of relapse because all those treatments do not prevent a relapse. So this was the revolution, which was the spesolimab. It's anti-interleukin-36. It was approved by the FDA in September 2022. And unfortunately, it will not be available in Egypt. It's difficult because it's extremely expensive. But anyway, the results are marvelous. Sometimes it controls the disease within 24 hours. There's a second trial now. They're developing the subcutaneous form of the disease of the drug where it's going to prevent the appearance of flares. In the pipeline, there is another anti-interleukin-36, imsidolimab, and there are a couple of other studies that might, I think the more investigations are going to be made, because these are one of the, what they call orphan diseases. They are rare diseases, and so developing drugs cost a lot of money. This is why they're expensive. Finally, I just want to remind you, why do we say that psoriasis is different from generalized pustular psoriasis? Clinically, histopathologically, the genetic association, the diagnostic features, and in treatment also. But you have to remember, and from our experience, GPP in 65% of patients appear in patients with psoriasis. So we don't need to forget that. Yes, biologically speaking, they are different, but also they appear together and can appear together. So finally, it's a rare, life-threatening autoinflammatory skin disease characterized by the widespread eruption of sterile pustules. It's a distinct disease from plaque psoriasis. The flares are accompanied by systemic symptoms like pain, fever, malaise, fatigue, and also sometimes multi-system organ failure. High unmet need in the treatment that rapidly and completely resolves the disease. Spesolimab treatment is resolving those patients within 1 week with marvelous results, but I wonder if the quite expensive treatments and they need to be given IV in the hospital. And now they are developing the new subcutaneous drug that might prevent the occurrence of flare. We need, of course, better understanding of the disease, and I think consensus on the diagnosis this was started by Professor Chun from the IPC with the pustular psoriasis group, with all her colleagues. I think this was a great beginning because she sees so many patients. So she's planning on doing like more development and more studies, and we need to have validated endpoints to be used consistency in the trials. And thank you very much.
Thank you very much, Professor Mahira. Amazing lecture. I think this field is going to develop very rapidly in the coming years.
I hope we will be able to get the drugs here because we have pustular psoriasis in Egypt. We have GPP, we all see it. I remember, in other areas of the world, it's not there. So we really need those drugs. So I hope that one day, they were very expensive here, very expensive.
Yes.
Even on compassionate use, if you needed to get the drug, it's extremely expensive. But hopefully, we might, a biosimilar might appear one day, Peter, maybe.
So what about the other conventional the old biologics?
They work. They do work. All of them.
Many of
I
them
remember
are approved.
Peter Chun said that she's tried everything. I think she started with, she gave infliximab, she gave adalimumab, she gave anti-IL-17, anti-IL-23. She said she's given everything. They work.
But we don't have head-to-head studies.
No.
May I also address this topic, and it was very fascinating to listen to your talk. In particular, since it started with von Zumbusch, and to see the bust in a photograph, it stands in our entrance hall. And I see it every day the way you have shown it there. What I think, there are certain aspects. First of all, there are different types of generalized pustular psoriasis in terms of systemic symptoms. And the most severe form that was described by von Zumbusch is something that I would now call a sepsis mimic, because it imitates sepsis, and we find patients on intensive care wards because the physicians thought they have a sepsis with a pustular rush due to bacteria, and they put them on severe treatment for sepsis, even though these patients have systemic symptoms from generalized pustular psoriasis. And I also can comment on the response to other biologics. They respond, generalized pustular psoriasis responds to every biologic that we have available for psoriasis. The difference is, there are, I think, two aspects different. First of all, the new IL-36 receptor antagonist, it works as a single infusion, and then patients are clear for 3 months, half a year, whatever, maybe until the next episode. When we use the regular biologics, TNF antagonists, IL-17, IL-23 antibodies, then we have to apply them in the regular
regimen of psoriasis.
And once you stop, they flare at once again. And this is a major difference to IL-36 RN antagonists.
Do you find the difference between pustular psoriasis occurring without psoriasis and those occurring with psoriasis? No.
And also we
The
don't
response
find,
to therapy.
we have looked at patients regarding the IL-36 RN mutations, and we found that irrespective whether there is a mutation in IL-36 RN or not, they respond to treatment. So IL-36 plays a role, but it is not always depending on a defect of the receptor antagonist. And the clinical experience, coming back to information and experience, is that if we use conventional biologics like TNF antagonists, they may not completely clear the clinical symptoms. But if they don't clear completely, then it is sufficient to give a very low dose of acitretin, 10 milligrams, and the patients are free of symptoms. And when we combine these, we may have the opportunity to use a less expensive biologic therapy. 20,000 euro, I think, is one shot of spesolimab now. We cannot afford this either. And we can treat patients with adalimumab for 2,000 euro per year. Then it could make sense to use these drugs. The problem might be only from regulatory aspects, because these drugs are not approved for generalized pustular psoriasis. So when we look for generalized pustular psoriasis in treatment, spesolimab is the only drug that is really approved. And therefore, other biologics would be off-label treatments in a way. Unless we call generalized pustular psoriasis, it's a form of psoriasis, then we can use it again. So this is a really complex matter, and I was really impressed how you did it, and maybe my experience can contribute a little bit to it.
Okay,
Thank you.
Peter, I think you.
Yeah, very inspiring talk. I enjoyed very much, Mahira. But I'm a little bit thinking about the availability of spesolimab, and then for a country where actually GPP is not so infrequent, where you can see this quite regularly. The clinical trials design or clinical trials often is intervention of a crisis, like the IV infusion and then the result after that. And now also the prevention of a relapse. But what I'm wondering is whether we could give more support for studies which look for the significance of an interference with the long-term course of the disease. That is, when it is difficult to have a maintenance of spesolimab available, still and I personally think that still the injection of an infusion with spesolimab could have an enormous effect on the long-term run of the disease. But we do not yet know that. But that's important for our cost-effectiveness studies, and then maybe reimbursement could be easier. Do we have the right evidence for reimbursement really at a level that you change the life of these patients?
Absolutely. I think maybe Peter, that those very, very sick patients definitely will need that, because like you were saying, some of those patients, even this young boy I just gave him acetretin and topical treatment. I know I did not solve the problem completely, but he improved a lot. But I mean, some of those patients are really very sick. They need urgent. So maybe if we think about it that way, but they're very, very expensive. Like they're 20,000 euros per injection. So this is...
Make one comment more again, because I think it's a very informative discussion, since it's all new to us. The reason is, one of the aspects is that spesolimab works only in half of the patients. Even though the publications say it is effective in GPP, it is only 50% of patients that respond. And one of the issues that is not solved yet, and we need to think about, is what do we do with those patients who do not respond? They have blockade of IL-36, but we don't know, are we now allowed to give another drug like TNF antagonists or IL-23 antibodies, or do we induce a state of immunosufficiency that leads to a greater risk of severe infections, for example? And this is an aspect that we should always consider. 50% of patients respond, but what do we do with the others who have received the drug that need an additional treatment because it is not under control yet? However, they have neutralization of IL-36, which is a very important alarm signal or mediator of early inflammation in terms of infection. That is really an issue for me. And I have no solution for it yet. And each time I address it, and the company, they ignore my question.
I think we have to stop here because we're way beyond. Yes. Thank you very much.
Just one last comment.
Okay.
We have 2 patients in the HIO. I haven't seen them clinically, but I saw their papers. They both have DITRA, and just to confirm and they are responding very well to adalimumab.
Yeah. Thank you.
Thank you very much.